Hello everyone, and welcome to Mental Health TV. Today we're going to be talking about a whole host of things. We're going to be talking about COVID, dual diagnosis, sexuality, sex, and we're going to be introducing and talking to our fantastic guest. But first, before I do that, can I hand you over to Vanessa, who's going to tell you a little about how you can join in tonight.
Hello everybody, looking forward to tonight's conversation. I'm going to be doing the social media tonight, so if you're listening to this via Unite Facebook page, you can send us any questions in the comments link, or alternatively, you can follow on Twitter via MHTV. So do send us your questions and I will ask Liz and our panel tonight. Thank you.
Okay, so I'm Nicky Lambert. Can I introduce you to our fantastic guest, Professor Liz Hughes?
Hello.
Can you tell us a little bit about how you came to be where you are today in these exalted heights of professorship?
Yeah, one of the 23%, I believe, as a woman. So I've been a mental health nurse since '94, and I worked in acute mental health and drug and alcohol services. I think I did a placement when I was a student on a drug service in Hampshire, and it just completely changed my whole view on drug and alcohol, and it just became my passion. So that's what I wanted to do. But I also wanted to kind of consolidate some of my training as well. So I did acute psychiatry as well as drug and alcohol. And then I ended up in London working in a community drug and alcohol service with people with quite complex and long-term needs. And I used to work across between what was then the dual team and Guy's Hospital, and I used to attend their referral meeting and pick up, new referrals, people with mental health and substance use. Then a post became available in Bromley, so then I became a dual diagnosis worker, which was probably one of the first commissioned roles of that type, and unbelievably tough job that was. Looking back, it was really, really hard. I was trying to work across lots of different sectors in a time when people hadn't really thought too much about this issue, and it was before the Department of Health had any guidance. So I did that for about a year and a half, and then a job came up at the Institute of Psychiatry on a large research trial, and they needed a clinician to design the training and deliver the training and be part of that team. So I applied for it and amazingly got the job. I didn't think I would get it. It seemed very intimidating to me as a nurse going into academia. And then I kind of did a PhD on the back of that. And then I've kind of done CPD, research, teaching, and kind of moved about a bit and ended up where I am now. So it's kind of one thing led to another, really. I wouldn't say I had a plan, but, kind of opportunities appeared and you just grab them, really, and just follow your passions. I think follow your passions and follow your interests, and things kind of happen from that as well.
So for people who don't know, can you tell us a little bit about what dual diagnosis is?
Dual diagnosis, it's a bit of a sort of dated term now, but we can kind of still use it because it still has a little bit of currency. But it's basically, from my understanding, is that it's people who have a co-occurring substance use and mental health problems, issues that kind of require, an integrated treatment. But also, the problem with dual diagnosis is people don't just have two problems. They have multiple needs, and needs that stretch back over time, often compounding each other, and ones that seem to really fox the services as they stand, because we do operate in silos. So when somebody presents with multiple needs, it does cause issues in terms of where is that person best placed to get their needs met. So that's the kind of, in a nutshell, it's people with that kind of co-occurrence of drug and alcohol problems, but you'll have different severities along each of those issues. So you might have severe mental illness and occasional cannabis smoking, which might be impacting on their mental health, right through to somebody who has opiate dependence and comorbid depression and anxiety. So that's a really vast population we're talking about. It really is an umbrella term rather than a very specific field as such.
I think I interrupted Vanessa. Well, you were going to ask a question then. Sorry.
No, it's all right. No, I was just thinking, I think last time we met, Liz, was a few years ago at Ian Hamilton's event, which was on women and drugs. And you've just alluded again to, well, two issues for me about gender. One is about the fact that you said only 23% of women in professor roles, which is really interesting. And the other comment I wanted to ask you about was just around gendered issues as a woman working in that space around substance use. What do you think the gendered issues are around substance use? And, you know, in terms of you being a woman working in that area, how do you think that has impact? So, yeah, so a question for me about the sort of inequality around women in roles like your own, and a question really about gender and addictions.
Yeah, okay. I'll start with the one about academic roles. I mean, this is not specific to academia. You see this in any industry really, that you see at the top. You'll see a disparity between gender and ethnicity as well. I mean, there's an intersection as well going on. It's not just about women and inequality. It's also having visible Black and ethnic minorities in senior positions in any organisation. That's another issue. And heaven forbid, the intersection of gender and ethnicity. So I think, I mean, we know that about 50% of people who get PhDs are men and women. So you've kind of got a nice equal gender split at that point. But it's the postdoc space that becomes the issue in terms of where the genders start to sort of divide. And I think it's complex. I think there's all sorts of things going on. I think women don't necessarily have good mentors that they can if you've got less women at the top, there's less women to mentor you. Yeah. So, you know, you often don't have that kind of role model or that support or that hand up. There's a lot of stuff that happens out of hours and, you know, international travel and conferences and meetings that women with small children just can't really engage with that environment. And certainly for me, having a small child, I remember there was a period of time when all that activity died down because I didn't want to be away from home and I didn't want to. And so there is, but then it's what happens to those women and how they get support to, you know, because one of the things about getting to senior academia is about your networks and who you work with. It's not just following your own. It's about who you know, what networks you have. Opportunities come from those networks to be a co-applicant on a grant. You get that grant, and then you might learn a lot by being part of that study, which means that you can then put that learning into your own lead your own grant, and all that kind of stuff needs to happen. And I just don't think the women often, for all sorts of reasons, get those opportunities. Some of it is just domestic. Some of it is about opportunities to progress in different ways that mean you don't have to be out after work having drinks with the boys, and, you know, you're not at that conference in wherever it is. You know, there's ways to do it without having to kind of be in that space. So we need to change how we work. But I'm wondering whether the remote ways of working since lockdown will actually help in some. It's not helping women, we know that, but those opportunities to kind of be at meetings might actually be there if it's all remote and you don't have to travel. So it's interesting. And I'm just trying to think if I've got anything else to say about that. I may come back.
Yeah.
I think I've been really lucky because I've worked with some really incredible women who've provided me with some opportunities and support and belief. But I've also worked with some fantastic male bosses who have really supported me with my sort of work-life balance, haven't put ridiculous demands that are impossible to meet, you know. And I'm a great believer in, you don't have to work 1 million hours a week to achieve. You know, you have to have some sanity and you have to have some balance. and it's about quality, not quantity, and also about being really focused about what you do. Don't try and do everything. And I've made these mistakes before and taken on too much, and then you end up with too many plates spinning. But keeping focused and keeping your eye on what you want to achieve and what you're interested in, and make sure that your narrative makes sense. You can save a lot of dead ends and kind of doing things because you think you should, and that kind of thing. So, and the second question about working in drug and alcohol services, as a woman, I can't. When I worked in drug and alcohol services in London, I certainly worked with, the clients were more male than female, because we know that women struggle to seek help around their drug and alcohol problems for all sorts of reasons. Some of it's about fears about childcare. Other it is just barriers, just even dragging your 3 children to an appointment, and often it just doesn't happen. So most of my clients were men in the service I worked at. So whether that has a difference than dynamic, I don't know. Certainly in the hierarchy of the service, it was quite equal. It was quite a lot of female managers and male managers. So again, I'm not conscious of any dynamics particularly in that environment. In fact, to be honest, I think working in mental health and in drugs and alcohol services in the 90s, I can't talk about it now because I don't work in those services now. I felt it was a more inclusive environment to work in than in the traditional psychiatric services. And I thought that majority of the staff had quite a specific approach, which I really liked. There was very values based, a lot of motivational interviewing, working with people's individual levels of what they wanted to achieve, very goal setting, very collaborative. And of course, we worked like that because we didn't have any compulsory treatment in drug and alcohol services. So we had to work in that particular way without that kind of frisson of, well, we can work on you like that, but actually if things deteriorate, we have other options. And so I really like that way of working. And I think there's a lot that we can take from that and translate into practice in mental health as well.
Yeah.
We're actually getting some questions in already, but before we come to them, I think it would be really nice just to hear a little bit about the work you've been doing recently. So you've been doing some work around COVID, if you can tell us a little bit about that.
Yeah, well, I've got a study called the RECO study, which we started in January. We're very excited to see a commissioned call on comorbid drug and alcohol and mental health, and that came out a year ago or so. And a group of us got together and applied for it. So we've got people like Gail Gilchrist from King's, Alex Capello from Birmingham, Harry Sumnall from Liverpool, John Moores, and various other. I can post the link later so people can have a look at the.
It's a bit of a super group then for people who don't know the area.
It's a fabulous super group. It's just like, it was just a joy. It was a joy to put the grant together, a joy to work with everybody. And we've also got Charlotte Walker, who's, you might know as bipolar blogger, who's our PPI co-applicant as well, who's fantastic. And I've worked with Charlotte before on other studies. And we've got some people with lived experience that will be contributing throughout the study as well. But that's basically a new approach to looking at dual diagnosis, in that we want to understand from a realist point of view, not so much what works, how does something work, but it's what works for whom and in what context. So we're taking a fresh look at the literature and the evidence base, and using that as a sort of framework to develop theories about the kind of, almost like the ingredients of what good practice might look like. And then from then on, we can make recommendations as to how we can take this forward as well. I think I can hear my dog coming.
We like the dog. It's good.
I thought she'd gone away, but I just heard some tippy taps. Anyway, I apologise to everyone if my dog person.
It's fine.
I might have to let
Absolutely
her in.
fine. Introduce her so that people know who she is, and then we'll just press on again.
This is Bertha. God almighty. This is Bertha.
I think people will love Bertha. I think we've just lost any focus that people are going to have about your research on COVID.
She's managed to appear on many meetings. So it's 3 stages. We're looking at the literature, which we've nearly completed, and we'll be synthesising that. We're mapping the dual diagnosis services that exist in the UK, which is fascinating because we can already see, I think I'm planning to create a bit of a map of hotspots because we can sort of see where dual diagnosis services have existed and have existed for quite a long time, and where they just don't really seem to have any sort of commissioned services. So that's really interesting because it's not because of the lack of prevalence, because this issue is everywhere. I'm really curious to find out why some places have it and why some places don't as well. And then we're going to do some. Yeah, and then we're going to kind of drill down into sort of 6 sites, and we're going to really kind of understand what's going on, and probably places where they've had fairly established sort of initiatives around this clinical issue. Places like London, Manchester, possibly Leeds, Birmingham, etc., etc. So we're going to look at kind of how they work, what service users say about what it's like to use the services, how it works for different people. So, I mentioned gender before. So, this model of care, does it work for men, but not for women? Does it work for people who are have a stable home? And does it not work for people who are homeless? What about people from Black and ethnic minorities, refugees, and on and on and on. So we're going to try and really understand and highlight some really good practice and things that people can learn and implement, and also think about recommendations for future research as well. So that should be finished by the end of next year, but we'll hopefully publish things as we go along as well.
That's really useful. So obviously,
back to COVID. I
was going to ask how the 2 things interact.
Yeah. So basically, it's you can't ignore COVID when you're doing research now, because it's impacted on literally everything in our lives. And so we were starting even the mapping. So we were trying to find out about services, and that's kind of had to be paused because, the services won't respond to emails whilst they're dealing with, a tsunami of crisis. And mental health and substance use services have had to rapidly change how they work in order to, respond to the needs for social distancing and remote working and PPE and new way, redeploying staff. So what we're doing is I've kind of started to kind of gather some anecdotal information about what's been happening in the UK around specific services and dual diagnosis, but also I've looked at the literature around mental health and substance use from countries that had COVID earlier than us, like Italy and China, and see what's been published. And so, just kind of pulling it all together at the moment.
So how is COVID impacting your client group?
Well, we don't really know for sure. We've got a number of concerns, I think, in terms of the physical vulnerabilities of this group. They've already got, people with serious mental illness, as we know, have significant comorbid physical health problems, such as kind of cardiovascular, lung issues, hepatitis C, etc., diabetes, obesity. These things will make you more vulnerable to COVID infection, sort of severity, I guess. So we've already got that kind of, you're already coming into it with a vulnerability. And then you've got the issues around where you live and how closely you live with other people. Do you live in hostels? Can you not socially distance? And on the conversely, you've got isolation as well, and lack of access to services and advice and support, all the peer support, all the groups you might have attended. Everything just stopped overnight. If you haven't got access to the internet, or you might have a phone, but you might not have enough data to access stuff online. all that suddenly, that really strips down what you actually have. So I'm really worried about the kind of longer term impacts of this period and kind of what it's meant for people. And one of the things we'll be able to do in the RECO study is we're interviewing people with lived experience who are kind of currently using the services and we'll be able to ask them not just about services as normal, but also what's happened during this period as well.
So what's your take on services? Because I understand people have been moved around to fill emergency gaps, and how's that impacting dual diagnosis services?
Yeah, well, quite dramatically, because there's a group called Progress, and they are a group of people that have been going for years and years. It's a kind of informal consortium of leaders in the field, mainly consultant nurses and other similar senior clinicians. And I'm a member of that group as well. So we've kind of been discussing and talking via email about what's been happening. And, there's issues around, suddenly being redeployed. So out of your leadership role into another role, just because the front line required that. There's issues around services being reconfigured, shall we say. So wards will close. And they'll be, sorry about my dog. She just wants to be in and out. Come here. And
she needs to get top billing now.
I think she does. Come on. And so, so people, so basically, what we've got to remember is even before COVID, there wasn't a lot of stuff going on for people with dual diagnosis, and even that stuff has been redeployed. So it doesn't really exist at the moment. And so when you've got a challenging situation where staff often require advice and help from, specialist roles, and those roles are not there, suddenly you're going to leave a lot of people managing in the dark, really, and in using new ways of working as well. So I do know that in some ways there's been some positive feedback that clinical staff have been asking for more advice about how to do brief interventions online, and things like that, and also about some extraordinary resilience that their client group has been showing, which is great. But part of me thinks you shouldn't have to be that resilient. You should just be able to get what you need. So, hats off to people for being really strong, but there'll be an impact down the line of having to be extra strong and, coping, but at what expense? So, it'll come out, and I think we haven't had a chance really to look at the real impact yet, but I'm sure there's going to be some pretty harrowing accounts really of how people have been trying to manage difficult situations on their own. Things like alcohol detoxes have kind of been reduced to only people who are very severe. And so a lot, people have been told to, we can't look at detox at the moment. We need to kind of just maintain you and not manage things like that. So the usual access to things is just gone, really.
I suppose it matters as well, doesn't it? If you've got your key leadership deployed elsewhere, no one's paying attention to keeping things going forward and progressing. That's really interesting. Thanks, Liz. Vanessa, do we have some questions?
Yeah, we've got quite a few questions. We've got lots of love for Bertha as well.
God,
I knew
do apologise. She's now trying to steal my cardigan off the chair.
She's stealing.
Give her the cardigan.
Sure, yeah. We've got lots of questions here. We've answered a few of them already, so I'm going to work through them. So we've got a comment here about dual diagnosis workers and nurses are often seen as a commission in luxury. How can we increase the awareness of coexisting health issues and substance use disorders?
Well, my answer would be we shouldn't really have to, because the stats speak for themselves. We've got about 30 to 50% of people in mental health services have coexisting substance use issues at one point or another. If you go to an inpatient ward, it's higher. Go to a forensic ward, it's even higher. Yeah. Then you look at, and I always hate using these statistics, but they're the ones that get people to sit up and take notice, is the National Confidential Inquiries in suicide and homicide. And year on year, Louis Appleby's team have highlighted this group as a group of concern. We don't have CPD anymore for people to access around dual diagnosis. Dual diagnosis roles are not a luxury, they're an absolute necessity. But we haven't really ever done any sort of evaluation of the impact of these roles. So it's a bit equivocal in a lot of ways. So we can't say, yes, if you have this specialist role, X, Y, and Z will happen. Yeah. But obviously, if you don't have those specialist roles, nothing will happen because no one's going to take a lead. And there's also the age-old battle of who commissions this. So if it's drugs and alcohol, it's Public Health England and it's local authority. If it's mental health, then it's NHS England and it's the CCGs. And maybe the siloing of the commissioning has been compounded even more. I mean, the role I had was commissioned by the DAT, the Drug Action Team, back in the day. 100%, although I spent a lot of my time working in the mental health services, working with their client group as well as people in our service. It needs a joint approach. So it needs joint commissioning. It needs the commissioners to work together and have a local joint strategy about how this is going to work. But without any sort of leadership at all, it's never going to happen. So I like the idea of, oh my God, there's another dog. What is going on? Come on.
Just let them all just do what they want.
Oh, yeah, do what you want. So I think, my job was a ridiculous example. So you commission one person, one G grade back in the day when it was Whitley Council, one G grade or one, well, I guess what would that be now? Band 6, band 7?
7 or 8.
7, yeah. So one person, one borough. So one nurse for one borough, the whole of Bromley. And the remit was sort dual diagnosis out between the council, the drug and alcohol services and mental health. And I was like, yeah, no problem. But when I actually tried to do it, it was impossible because your impact is so minimal. I had a caseload of about 15 people, which took up a big chunk of my week, quite rightly so. The rest of the time was used on liaison and training and going to wards and talking to staff. But it took months to for people to even know who I was, because every time I went to the ward, it was a different set of staff. So you really do need a strategy that operates above, but you need some real good grassroots workers in every aspect of the service to provide that just that working alongside people. I mean, one of the things I used to do was go and do an assessment on the ward, and one of the things we did was collect a urine screening just to see what people were using. And the staff was saying, how come you can get people to give you a sample? And I went, because I just asked them. And they were like, oh, and it's something about back to what I was saying before about the approach that you use and the values. That's really important. And we've done a lot of work with service users and people with lived experience. And one of the things they say over and over again is this attitudinal stuff that they want. They want people to listen to them. They want people to value them and respect them and just try and understand. And I think that's the thing that is actually more important than what technical skills, whether you're using CBT or MI, or it's having those values that are really important.
It's not a lot to ask, is it? It really shouldn't be.
No, but we have really difficult attitudes towards drug and alcohol in society, and then in mental health, it's often seen as a self-sabotaging behaviour. So, oh, you wouldn't be back in hospital if you hadn't started drinking again. And there's a lot of blaming, and it's just so counterproductive. And I think it's because a lot of people don't have that kind of understanding of where the drugs and alcohol fit into the whole picture. And it is a coping strategy. It's a form of trying to manage every day, and it's putting it into context. And only things like training and CPD and supervision can really help people address that. And it's something that probably should be, oh my God, it should be something that is in our student nurse training as well.
Yeah.
But where are the experts in substance use now? We've kind of lost a lot of our leaders and services. And so there isn't much input into our nursing curriculum either. So I'm not surprised it kind of perpetuates.
We've got absolutely tons of questions coming in. So I'll go back to Vanessa. Just do your best, Vanessa.
Yeah. So we've got, do we have an overview of how COVID-19 has impacted on the presentation of dual diagnosis in mental health trusts? So we've kind of covered a lot of that, I guess.
Yeah.
And then we've got Natalie, would be interested to hear thoughts on how the NICE guidelines, which suggest services should not have standalone dual diagnosis teams, impact on care for this group. In my experience, instead of increasing access, it simply reduces it further and waters down specialist skills for dual diagnosis. So we've covered a lot of that as well, haven't we, really? But anything...
Yeah, is that question saying why we don't have specialist teams?
It says, suggest services should, it's basically saying about the NICE guidelines, suggesting services should not have standalone dual diagnosis teams. And she's saying instead of increasing access, it simply reduces it further and waters down specialist skills.
Yeah, I think we need specialists. We've got to have specialists. They don't necessarily have to be. I think there's too many people that fit into this category for a team. Like we've seen this when we started splitting CMHTs down into specific teams, and then you have to try and fit people into, is it early intervention? Is it AOT? Is it this? Is it that? And I think adding a dual diagnosis team, it would be packed and then static, and you'd never move on. So I think you need leaders, you need role models, you need a plan, you need kind of a cascade model. So you need leaders, you need link workers, you need in every clinical service there should be somebody with a special interest. A bit like you might have someone with a special interest in eating disorders. I think we need these specialists that we can all learn from. And I could probably think of a number of areas. I think somebody who's has expertise in personality disorders, for example, because again, that's an area where it's very emotive. People have lots of opinions about it, a lot of unhelpful responses to people with that label. And yet there's actually quite a lot of, understanding now and recognition of actually working in a more trauma-informed fashion is actually a really positive way to work. And getting away from this kind of diagnosis of exclusion. And I see the same attitudes to drug and alcohol, and I get it. I get that, people might perceive this group as really challenging, and I didn't come into mental health to work with drugs and alcohol. I've heard it. I've literally heard it a million times, but I've also heard it in drug and alcohol services. It's like, I want to work with people with actual proper drug problems rather than someone who smokes cannabis. It's like, what are we doing?
Why do we get the idea? Why a nurse would suddenly think that they can order a patient group off a menu? I'm like, that's not about you. You're here to do what they need, not what you'd feel like. I feel like depression today. That's not how this works. Yeah, really bizarre.
No, we're here to serve. And it's what comes through the door, and we have to adapt to those needs rather than. And I have worked. And I think if people do, I think people get triggered by different things, and that's important to recognise. And staff will have all sorts of their own internal stuff going on, but that's where supervision, and this is a thing, I've talked to lots of people recently about where's our clinical supervision here. A lot of this stuff could be nails if we had proper clinical supervision that got us to question our reactions to certain groups and certain behaviours, and then think about how we can move beyond that as well.
I think you've touched on it about trauma, and it's certainly reflected in some of the questions and some of my own thinking, having worked in prisons, that we work within a very medical model where we separate, as you say, depression from addictions and so on. And perhaps, reframing something within a trauma perspective is part of the solution. And we've got some thoughts on that here in terms of the curriculum as well, and some suggestions that one of the ways of addressing the gaps in the curriculum are to look at things from a trauma-informed perspective.
Totally agree. Totally agree. That having that, rather than going, oh, today we're going to do drug and alcohol, today we're going to do personality disorder, today we're going to let's look at the kind of the trauma-informed approach, and then the things that spring out, the manifestations of that is that all we're talking about. So drug and alcohol, self-harm, hallucinations, flashbacks are all manifestations of a central kind of core understanding, and then having an explanation for behaviours that might not seem understandable at the time can really help people with their compassion and kind of alternative responses, really. So I think that's to me that's critical.
Yeah, definitely. And I think it fits in with what you were saying about some of the structural issues around being a diagnosis of exclusion, which I've seen certainly working within prisons and referring people to specialist mental health services, and people being refused because of their sort of active addictions or for other forensic issues.
And that's one thing that really winds me up, is this arbitrary, you can't have any mental health care until you're sober or not using drugs, because we were able to do talking therapies with people on crack and heroin and opiates and benzodiazepines, and but we still managed to have very useful therapeutic sessions with people, even with that, because they're tolerant. It's not like they're not intoxicated, they're tolerant. So they might be taking a whole load of drugs, and yes, there might be some numbing there, but actually that can be quite safe, because I've seen, we did this work with a particular person who'd had a lot of trauma, and she was drinking a lot, and so she started doing some therapy and stopped drinking, and she literally fell apart without the alcohol. I'm not suggesting alcohol was the right thing to do, but the whole thing together, with taking away her safety nets, with then bringing everything out of the thing, was quite something to behold. And it didn't feel very it didn't feel very helpful at the time, and we did go into a mental health crisis with this woman because of that. And I think, looking back, things need to be handled in a very different way, and kind of paced, careful way, especially with people with lots and lots of traumatic experiences. Sometimes the drug and alcohol is all you do. Sometimes that's all that's holding people together. It's getting people through, and we've got to be really delicate around the advice we say about take that away. If you stop using that, then everything will be fine. Often that's not the case. I've seen.
It's odd, isn't it? Because it's a coping strategy. You can't take away a coping strategy before you've put another one in place.
Put another one in, absolutely. And otherwise, you do it incrementally. You do it incrementally. You do it in a safe way, absolutely.
I've also, I know we've got loads more questions, but we are nearly through our time, so that's happened really fast.
Wow,
before we sort of take the last round of questions and things like that, I thought it'd be really useful, because we were talking about some of the kind of COVID issues, and we haven't got through half of the things we wanted to talk to you about. So I think probably we'll be having both you and Bertha back another time. Can you tell us a little bit about infections and PPE? Because that's something I think that's current for this present time that people need to be a bit aware of.
Yeah, so I think probably things have moved on, but certainly what I was hearing at the start of the pandemic was certainly mental health, not having access to PPE as a standard approach. So, and conflicting advice about when you should don it. And, you know, I've heard, and this is all anecdotal, I don't have, this is not research or anything like that, but, you know, I've been hearing things about, oh, you only use PPE if you know someone's COVID positive. And back in that, you know, back in sort of April, we didn't even have access to testing. So, you know, half the time you didn't know who was positive or who wasn't. And I think the mental health services have had to play a bit of catch up on physical health and barrier nursing and things like that. We've all had to go on a very steep learning curve around how you manage infection and things like that. There's even kind of, you know, movements to kind of full uniform, even for the community, just because of this idea of, you know, wearing something you can wash and take off before you go home is actually quite important. But the other issue around infection and mental health is around, and drug and alcohol, is about, you know, sharing equipment for drug use. For example, now we know COVID's in every body fluid. We know that if you touch something and someone else touches it, it's, you know, it's an infection vector. So, you know, there's issues around how people have been taking drugs during this period, you know, what they've been exposing themselves to, and whether they've been able to access the needle exchanges and other things that they would normally be able to, you know, pop down a chemist. But I don't know about you, but the queues outside the pharmacies and letting one person in and out will prohibit anyone just popping in for a needle exchange. So, you know, you know, the idea of going into lockdown and having one exercise a day, and, you know, I just think all the things that people might have been accessing have gone out the window in a way. So I do worry about infections, not just COVID, but also, you know, bloodborne infections as well.
Absolutely. Well, do you think there's been any positive or any positive changes at all brought by the kind of new experience that we've been through?
Yeah, I mean, I think we've all kind of identified some positives out of the experience, and certainly what I've heard. So, what again, anecdotally, I've been told, you know, people have been impressed with the resilience that their client group has showed, but also the fact that remote methods have worked for some of the groups that they perhaps didn't think they would. So I know somebody who works with people with homelessness and complex needs, and actually she's found accessing them through telephones and other methods actually quite effective, and in some ways more effective than the old system of expecting them to pitch up at your service at a set time. You can give them a ring. If they don't answer, you give them a ring again, you know, an hour later, and you might get hold of them, or you can text. But just using that, because I've always had this thing that the health service and other services have this thing about, oh, we can't use phones, we can't text people because it feels like it's too personal, or it's not quite professional. But actually, I think, you know, people use WhatsApp now. It's a kind of really easy way of getting in touch with people. You can see if someone's read your message. And that's kind of worked really nicely, I think. And I think hopefully we can take the best of these methods, but also obviously bring back the kind of more holistic face-to-face stuff as well, that works.
It's interesting. It's disrupted a lot of expectations, and I think as well challenged some of our staff having quite low expectations of what people are capable of.
Yeah.
Turns out
people are capable of managing as well. And the other thing, and I know with the Public Health England guidance on dispensing of opiate substitution therapy, people who were not allowed to, you know, even have their own responsibility for their methadone and other opiate substitutes have done really well with being given, you know, a week at a time, or, you know, gone to non-supervised dispensing, just because you can't have someone pitching up at a pharmacy every day or down at the clinic every day. So being given people more responsibility, people have risen to that as well. And I think there's been some issues. There'll be some people where it hasn't worked, but I think it's how we manage risk in the, you know, and there'll always be people it won't work so well for. and then those people it does work for, it's at their expense as well. So I think we need to think about positive risk taking a little bit more as well.
We'll have to now.
Well, we've been forced to. So I mean, it's good. It's good shaking things up.
Yeah. Let's have one last batch of questions then. So Vanessa,
we've got quite a few questions which we're not going to have a chance to cover, but just to reassure people that we will go back through the thread afterwards, and any outstanding questions we will ask. Answer. But one question in particular I wanted to ask Liz, and I'm not sure where this person's from in terms of the advice you can give, but it says, how can I find support for butane abuse alongside my diagnosis of EUPD? So any awareness of any services specifically supporting people who are abusing butane gas?
I think most services should be able to offer some advice. I mean, I've always treat any sort of substance. It's not so much about the specific. I mean, obviously there's kind of safety issues around butane and things like that. But to be honest, you know, the way you approach helping people understand their use is generic, and any local drug service should be able to offer some advice. And there's also, you know, I can dig out some links. There's other websites for advice and kind of information about it, but actually the local drug service should be able to at least offer some sort of level of advice, and then if need be some kind of, you know, ongoing support.
Yeah, that's great. Thank you. We've got time for one more, Nicky?
Yeah, we'll do a couple more.
Yeah, okay. Another one here then. Do we know how widespread screening and brief interventions for alcohol misuse is across mental health trusts? So do we know how widespread screening and brief interventions for alcohol misuse is?
Well, it should be. It should be, because it's part of what happens when people are admitted to hospital. They should be screened for alcohol. There are. It depends on what you mean by brief interventions, because there's obviously a whole range of stuff going on, and I think there will be some stuff going on in some trusts where they have staff trained in delivering there's a particular approach to brief interventions for alcohol. I mean, I think it should be bread and butter of any mental health nurse on any ward should be able to deliver brief interventions. I wouldn't like to hazard a guess as to how widespread. Definitely the screening, this audit is part of standard data collection, as is smoking, you know, smoking cessation questions as well should be part of standard care. The problem I always have is people ask the questions, then what do we do with that information and what do we do as a consequence? And it's whether that actually progresses into some form of brief intervention. So there was a really nice study done in Birmingham by Alex and Emma Griffin and Hermine Graham. That group over there in Birmingham did an actual feasibility study of brief motivational interviewing interventions for substance use in inpatient services. You know, that's a good example. So I certainly know that Birmingham definitely have staff trained to deliver that kind of intervention. But I wouldn't know exactly what's happening elsewhere.
Okay, I think we're going to have to. Have you got one more there, Vanessa, or should we stop?
No, I think we've covered most of them, to be honest.
Brilliant.
And the comments that we've and discussion we've had. So yeah.
So we don't want to cut people off, because obviously we're really grateful and pleased that you feel able to interact and ask questions and join in. So anything we've missed, we'll go back through the string and check. But I guess we're going to finish up now. So before we do that, can I just come to Vanessa and then Liz to see if there's any last words, anything that people would like to say before we finish on this subject?
Yeah, I mean, for me, it's just been a really useful conversation. Thank you, Liz. And I feel that we've only just kind of touched the surface of this. And there's a lot that we should come back to, particularly, you know, around some of the sort of structural barriers and the values. And I guess it might be good for us to do something on trauma-informed perspectives one week as well. So I think for me, it's just been really, really useful. But I think, we need to probably come back to this conversation. It's really important. And thank you.
Liz?
Yeah, I think COVID has just highlighted inequalities across the board, and the plight of people who have multiple needs, who use mental health and substance use services. I've been doing this for 20 odd years, and I still feel like I'm saying the same stuff, and it's frustrating in a way. I feel like we need to kind of really get to grips with this issue and not see it as a kind of add-on, but just see it as very much a core part of mental health. Core part of mental health nursing is to work with substance use and mental health.
Yeah, agree.
Absolutely. I think we've got to stop suggesting that everyone fits into our team planning, our service provision, and our fantasy about how we'd beautifully like to deliver some kind of therapeutic intervention. If it wasn't so messed up by the person who's supposed to be receiving it all the time, then that's absolutely bonkers, isn't it? When you think, why are we mad at people for not fitting into a system that's supposed to be designed for them?
Exactly.
It goes round and round. But I was hoping to talk to you about all your work on sex and sexuality and mental health. So we'll have to rearrange for 18. Our 18 edition.
Don't set me off on that one.
We're going to set you off on that one.
Yeah.
On a later date. But thank you ever so much, everyone, for watching, for participating, and very much thank you to Liz, our guest. All right. Good night.
Thank you. Bye.
Bye. Thank you.